Good morning, everyone. It's the top of the hour, so we will get the webinar started. I'm Laura Benzel with the IPRO QIN-QIO. Welcome to our webinar, Strategies for Providing Affirming Care for LGBTQ+ individuals. We really appreciate you taking the time to be with us this morning. As I just mentioned, this webinar is being recorded. The lines will be muted for the duration of the presentation to reduce background noise. And you'll be able to access the slides and recording for today's presentation on the IPRO website. We will be sending an email to all registered attendees with a link to both the slides and the recording. So even though we have the lines muted, we would really like to keep the event interactive. So please enter your questions and comment via the chat feature. My colleague Susan Brittman will be monitoring the chat throughout the webinar. So you may be familiar with WebEx, but just in case you're not, if you look at the bottom of your screen, you'll see the conversation bubble, and that's what you click on to enter into the chat. And you just want to make sure that in the drop-down menu, you select everyone. I think it's actually the last selection, so you have to scroll down. But if you don't select everyone, then everyone won't be able to see your comment. So just be sure to do that. And then after you enter your comment, hit enter on your keyboard, and that will display it into the chat. So today's event is a cross-task webinar, and what that means is we have participants from both the IPRO QIN-QIO and HQIC networks. I'll explain those acronyms in a second. And I just will take a moment to introduce IPRO for those of you who may be new to our webinars. So the IPRO QIN-QIO is a federally funded Medicare Quality Innovation Network Quality Improvement Organization, or QIN-QIO. It's led by IPRO, joined by health-centric advisors and Clarent. Our network works with hospitals, providers, nursing homes, and other stakeholders in the 11 states that you see here on the screen and the District of Columbia to ensure high-quality, safe health care for 20% of the nation's Medicare fee-for-service beneficiaries. IPRO is also a federally funded Medicare Hospital Quality Improvement Contractor, or HQIC, in the 12 states that you see here on the slide. IPRO is collaborating with health-centric advisors, Clarent, Q3 Health Innovation Partners, the Kentucky Hospital Association, and Superior Health Quality Alliance to support participating hospitals by facilitating quality improvement strategies to improve patient safety and reduce all-cause harm. So I'm very pleased to introduce our two expert speakers today from Fenway. Chris Grasso is the Associate Vice President for Informatics and Data Services and has over 20 years of experience working in the healthcare, public health, research, and technology fields. Under her leadership, Fenway has been an early adopter of health information technology, and she has developed tools to improve data capture and support clinical decision-making. Dr. Alex Garoglian is the Director of Education and Training Programs at Fenway, and he's also the Associate Professor of Psychiatry at Harvard Medical School. They are Principal Investigator for the National LGBTQIA+ Health Education Center, a HRSA-funded cooperative agreement to improve healthcare for LGBTQIA+ people at health centers. They are also concurrently Principal Investigator of the Innovative Intervention Strategies Coordinating Center for Technical Assistance, also funded by HRSA to implement emerging strategies nationally for people with HIV. So thank you both very much for being here today. I'm going to stop sharing my slides and hand it over to you, Chris.
I think I just need the, oh, thank you. Okay, Alex, can you see my slides?
Yeah, I can see them. Thanks so much, Chris. Well, hi, everybody. Welcome. We're very grateful to be here. Thank you to IPRO for inviting us to spend time with you all. And we're going to be talking about strategies to provide affirming, responsive, and high-quality care for LGBTQI+ communities. And that's a very broad topic. We have, 4-day conferences. We run on that topic and have a national center that produces many webinars and publications and interactive learning modules to get folks situated in that regard. So we're going to focus in the 50 or so minutes we have together now, specifically on a central component of providing culturally responsive care, which is collection of patient sexual orientation and gender identity data within healthcare and health systems. My name is Alex Krogley, and as was mentioned, I direct our Division of Education and Training, which includes the National LGBTQI+ Health Education Center. I'll be starting us off, and the second half of today's presentation will be by Chris Grasso. Chris, do you want to briefly introduce yourself as well?
Sure. Hi, everybody. Chris Grasso, Associate Vice President for Informatics and Data, and looking forward to our conversation today. Thank you.
Great. A word about Fenway Health, which was mentioned earlier. We're a federally qualified health center in Boston. We just celebrated our 50th year in existence last year. So in 1971, Fenway was founded, and from the beginning has been focused on providing the highest quality care for sexual and gender minority people, and also people in the neighborhood who happen to receive their care with us. We're the largest provider of transgender health services in New England. We see over 4,000 transgender and gender diverse people in primary medical care each year. We're also the largest provider of HIV services in New England, and we, in that regard, serve over 2,300, I believe, people living with HIV in primary medical care each year. We're an integrated health system where health, behavioral health, HIV services are all incorporated into our primary care model. And we're unusual as a federally qualified health center in that we have an institute, the Fenway Institute, within our health center that focuses on research, education, training, advocacy, and policy for LGBTQI+ people, people living with HIV or at risk for HIV, and health equity more broadly. Next slide, please. Thanks, Chris. Within the Fenway Institute is our education center. As I mentioned, we offer many webinars by national experts that are then archived and available for free. We have interactive learning modules on a range of topics, best practice guidelines, over 80 in fact, including this one on how to create a transgender health program. And we offer continuing education credits and health equality index credits through the Human Rights Campaign. All of this is available for free at lgbtqia.healtheducation.org. So I encourage you to check out our resources. Next slide, please. Why is it important to have health programs that are tailored for and culturally responsive to the needs of LGBTQI+ people? The Institute of Medicine, Healthy People 2020 and 2030, and the National Academies of Sciences, Engineering, and Medicine have convened experts, reviewed the existing literature, and concluded that there really are unique health inequities experienced by LGBTQI+ people, and that the way to address these health inequities is to know the sexual orientation and gender identity of all our patients, so that we can provide culturally responsive, tailored care based on that information, so that LGBTQI+ people can enjoy the same standard of health as the general population. Next slide, please. I've used this term LGBTQI+ like it's one homogeneous group where everyone has the same experiences and the same health needs. The reality is each of these subpopulations that I've separated intentionally with commas here, the L, the G, the B, the T, the Q, the I, the A, and the plus, which indicates that we're inclusive of all sexual and gender minority communities, all have unique life experiences and unique health needs. So let's go through this together to think about things in a more nuanced way. There are a lot of concepts and terms that get used when we first start focusing on care for LGBTQI+ people, and that come up in the context of data collection. So let's go through this together to make sure we're on the same page. First big point to make is that gender identity and sexual orientation are not the same thing. These are two different experiences, two different concepts. Everyone has both a gender identity and a sexual orientation. So each of us participating in today's session has one of each. And the concepts and terms we used 20 years ago are different than the terms we used 10 years ago, 5 years ago, even a year or two ago. I'm hearing new terms in the last 4 to 6 months from my particularly younger LGBTQI+ patients that I hadn't heard even a year or two ago. So part of this is a very rapidly moving societal, cultural, linguistic revolution that we can view with a sense of intimidation and being overwhelmed, but we can also view it with a sense of excitement and adventure and an opportunity to learn and grow. How a given person identifies will also evolve throughout their life as well. So someone may initially identify as straight, later identify as gay, someone may identify as a man, and later identify as a woman. So in SOGI data collection, we don't just ask these questions once, check a box, breathe a sigh of relief, and move on that we did our job. These are dynamically evolving health-related variables, so we recommend asking about them every year, if not every 6 months, and Chris will talk more about that. Next slide, please. First important concept is that of sex assigned at birth. When babies are born in countries and cultures around the world, they're typically assigned one of two sexes based on physical characteristics. In some cases, they're assigned intersex status if they have variations in sex development that don't fit traditional societal notions of female and male bodies. Next slide, please. We now know and appreciate that these babies grow up, become children, adolescents, and adults who may have a gender identity that doesn't align with society's expectations based on the sex they were assigned when they were born. And important to that is the idea of gender identity, a person's core inner sense of being a girl, woman, boy, man, something beyond girl, boy, or woman, man, or having no gender at all. And we appreciate that many people have what we refer to as a non-binary gender identity, which doesn't fit one of the two traditional gender categories of either being a girl or a boy, either being a woman or a man. So we think about this constellation of gender identities. Gender expression is a related concept. It's how a person presents or communicates their gender to other people and to the outside world. And that can be through their mannerisms, the way they walk, their dress, their hairstyle, their voice. And this is going to vary by context, by culture, and for a given person will evolve. For example, someone may have a more traditionally feminine seeming gender expression at school or at work and a more masculine appearing gender expression at home, whatever that means, right? Next slide, please. What does the term transgender mean? It's an umbrella term for people whose gender identity doesn't align with society's expectations based on the sex they were assigned when they were born. And people may identify in binary ways. They're assigned male sex at birth and identify as a woman. They may identify as a transgender woman, a trans woman, simply as a woman. If they're assigned female sex at birth and identify as a man, they may refer themselves as a transgender man, a trans man, simply as a man. People may identify in non-binary ways. They may identify as non-binary. They may identify as gender queer. They may identify as gender fluid. Gender fluid implies a gender identity that's more dynamic and potentially going to evolve over time. And we increasingly use the terms transmasculine and transfeminine that are more inclusive of people with both binary and non-binary gender identities. A transmasculine person, someone assigned female sex at birth who identifies more with masculinity than with femininity. They may identify in a traditional binary way as a man, or they may not. Next slide. Thanks. So that was gender identity. Separate concept is sexual orientation, and this is how a person experiences their own physical, emotional, and romantic attachments to other people. It's helpful to think about this in three components. There's desire, whether someone is attracted to other people or what genders they're attracted to more broadly. When I was in med school, I was trained to ask, are you attracted to women, men, or both? We've really moved beyond that. Now we ask, do you have attractions to other people to make room for asexual or aromantic people? The person says, yes, I do. Then we might ask, who are you attracted to generally? What are the genders of the people you're attracted to? Assuming that's even relevant for the care they're there for. Second component of sexual orientation is behavior. This refers to what kind of sexual or intimate activity someone is engaging in and what type of activity. And the third component is identity. And this refers to the range of labels and communities that exist in society that a person may or may not affiliate with regarding their sexual orientation. Some of the more common ones include straight, gay, lesbian, bisexual, queer, asexual, pansexual. With both gender identity and sexual orientation, it's important to note that we can't assume persons' gender identity or sexual orientation based on how they look or how they sound. It's what they tell us, and that's what we document in healthcare systems. So there are plenty of men who have sex with men, as an example, who don't identify as gay, bisexual, or queer, identify as straight. So we ask people, and we reflect their own language back. Next slide, please. What does the Q stand for? It can stand for someone who's questioning their sexual orientation or gender identity, hasn't settled on a particular one. It can also stand for queer, which 100 years ago meant bizarre, strange, or odd. Mid-20th century became a derogatory term, a slur for sexual minority people, gay and lesbian people, for example. And a couple of decades ago, it was reclaimed by the community who said, you call us queer to hurt us. Okay, well, now we're going to call ourselves queer, and we're going to do it with pride, so you can't hurt us anymore by calling us queer. And lo and behold, there are queer studies departments in colleges across the country now. As with these other terms, we can't assume people are comfortable being called queer unless they tell us that. For people of a certain age, it may be the last thing someone called them on the playground as a kid, in school before they were harassed or beat up, and can be associated with a lot of trauma and triggering. So we ask people, we don't make assumptions, and we use the language they provide us. Next slide, please. To understand the health disparities and inequities that we're trying to address with this sexual orientation and gender identity data in healthcare, we increasingly use the minority stress framework. The idea that LGBTQI+ people from childhood through adolescence and into adulthood experience everyday discrimination, victimization, microaggressions, frank violence, unfortunately, at a higher prevalence than the general population. We think of all this as external stigma-related stress, which over time for many people can be associated with disruptions in certain general psychological processes. If we click forward, like disruptions in emotional regulation, interpersonal functioning, having certain beliefs or cognitive structures that may be understandable and protective in the moment, but can perpetuate distress, like believing it's never going to get better, nobody can be trusted, no one will ever love me. And external stigma-related stress can lead to internal stigma-related stress, internalized homophobia, internalized transphobia, believing all the negative things society has to say about your identity or expression, expecting rejection because you're so used to it, or identity concealment to prevent mistreatment and abuse. All this stigma-related stress we think is related to what we see in research, which is a higher prevalence of behavioral health problems like depressive disorders, anxiety disorders, post-traumatic stress disorder, substance use disorders as a way to cope with all this stress, decreased self-care, decreased engagement in healthcare, including primary medical care, behavioral health care, and down the road, a much higher prevalence of various physical health problems as well, if we click forward to the end here. So this is really important to understand in terms of why we're so motivated to integrate SOGI data and our own responsive care with SOGI data into health systems across the board. Next slide, please. Stigma we think of in three components. There's interpersonal stigma perpetrated between individuals, can be from a member of a care team to a patient and can occur across a person's lifespan. It can be between colleagues working within healthcare as well. Next slide, please. Structural stigma refers to institutional or governmental policies that intentionally or unintentionally restrict the opportunities and freedoms of certain groups of people. One example is access to all gender restrooms. It's important for health systems to have all gender restrooms for trans and gender diverse people. I know people have been pulled out of restroom stalls because someone complained, objected to them using a restroom based on how they looked or how they sounded and called security. So this is really critical. At Fenway, all our single occupancy and multiple occupancy restrooms are all gender. Next slide, please. Yeah, great. And there's intrapersonal stigma, the kind of internalized homophobia and transphobia I was describing earlier. These are often associated with a lot of shame and social isolation and can be hard to shake even after someone comes out in terms of their sexual orientation or is affirmed in their gender identity. Next slide, please. These health issues start in childhood and can evolve or persist throughout the lifespan into adulthood and even older adulthood. We just look at some of these with the next slide, focusing initially on disparities among youth. LGBTQI+ youth are 2 to 3 times more likely to attempt suicide, much more likely to experience homelessness, much higher risk of HIV and other sexually transmitted infections. Despite an overall decrease in HIV incidence in recent years, according to the CDC, incidence remains high and stable among Black men who have sex with men and is increasing among gay and bisexual Latino men, particularly those ages 25 to 34. So there's this intersectional challenge, an epidemic of HIV among gay and bisexual men of color that we really haven't started to make a dent with from a public health standpoint. Next slide, please. The US Trans Survey of 28,000 people across the country, including from every US state, found that trans folks are much more likely to experience serious psychological distress than the general population, have a 40% lifetime suicide attempt prevalence, which is higher than for any other studied population. And it's hard enough to find providers confident and competent to provide gender-affirming care, but very high incidence of being denied insurance coverage for gender-affirming surgery and hormone therapy, even though these are considered medically necessary by the American Medical Association since 2008. Next slide, please. Trans folks in the US Trans Survey also report very high occurrence of negative experiences with healthcare providers, like being verbally harassed, refused treatment, or denied care because of their gender identity. Very likely to not seek needed healthcare, urgent and preventative care due to fear of gender-related mistreatment. And many didn't go to a healthcare provider simply because they couldn't afford it in the context of pervasive employment, economic, and housing discrimination. Next slide, please. Older LGBTQI+ adults experience a lot of disparities as well. These are folks who often came up at a time when they had to be closeted in many cases, estranged from family, may not have children, and we'd like to think that in their golden years, they could live openly and freely. Unfortunately, we hear a lot of heartbreaking stories about older LGBTQI+ adults having to go back into the closet when they access assisted living facilities or other services for older adults to prevent mistreatment. It's not all bad, right? This is a population with enormous resilience. It's overcome tremendous obstacles, achieved greater and greater integration into the mainstream fabric of US society in just a few short decades and years. Last year, we had Senate confirmation of our 2 first out presidential cabinet members in terms of an out gay man as Secretary of Transportation and an out transgender woman as Assistant Secretary for Health and Human Services, second highest ranking person in healthcare in the US government. So it's important for us also as care providers to help our patients, particularly younger people, feel connected to that broader resilience and strength in the community, which can be a source of great empowerment. Next slide, please. Now, to achieve health equity and improve the quality of care within health systems, we think of this in 4 components. There's ending invisibility of LGBTQI+ people in healthcare. That means knowing the sexual orientation and gender identity of our patients, asking this systematically, and providing culturally responsive care. It also allows us to engage in population health management and iterative quality improvement that Chris will talk about. We like to say, if you're not counted, you don't count. We can't improve care for populations we're not seeing visibly. Second component is clinical education, and that includes a number of skills that we're not taught in medical school, nursing school, social work school, psychologist training, that are unique and things that we really need to do for LGBTQI+ people, like gender-affirming hormone therapy, gender-affirming surgery, obviously. I have time in my week where I evaluate folks for gender-affirming surgery as a psychiatrist, not something I was taught to do in medical school or residency. It wasn't until I got to Fenway and started working with a very high volume of patients. Sensitive, effective communication is also important for creating inclusive, affirming care, and we'll talk about that. And thinking about building inclusive and affirming care environments broadly. That includes the physical environment, what posters, pamphlets, brochures you have in the waiting room, for example, and the policy environment in which we deliver care. Next slide, please. In terms of population health, when we would do these trainings, Chris and I in person around the country, we would ask people with a show of hands, healthcare professionals and often clinicians, to raise their hand if they've ever been asked by their own clinician at any point for their sexual orientation or gender identity. And we never had more than half the room raise their hands, even in New York, San Francisco, Boston, Los Angeles, Chicago. And admittedly, as clinicians, we do a terrible job of asking all patients these questions. We do focused histories, we cut corners, we think we know when it matters or when it doesn't, or we think we can tell even though we can't. So it's important to have a different systematic approach that's going to be more reliable within health systems. And that's really working with frontline staff, registration and intake staff to systematically ask these questions as demographic health-related variables. Next slide, please. Here's an example of why this matters. Rodrigo is a 40-year-old trans man, came in with pelvic pain and spotting. Biopsy determined that Rodrigo had cervical cancer. He was receiving care within a health system that wasn't asking patients systematically for their gender identity in a sensitive, effective way. Therefore, he didn't feel comfortable disclosing his transgender status. And unfortunately, no one realized that Rodrigo would benefit from a cervical pap test. So when we hear people say, well, I don't want to be rude, I want to ask all the patients these questions, really the rudest thing we can do and the way we're going to most offend people is by not collecting this critical health-related information, and that leading to really adverse, tragic health outcomes like Rodrigo's. Next slide, please. So everyone has a role to play in this process. Clinicians need to learn about LGBTQI+ health, the range of experiences that exist pertaining to sexual orientation and gender identity, and how to provide tailored culturally responsive care related to this. Non-clinical staff, front desk, registration staff need to also receive training in LGBTQI+ health, need to know how to field concerns that patients may have about why we're asking for this information, and know how to document this accurately within the electronic health record for all staff to refer to and be able to communicate in a sensitive and effective way. And patients deserve to know why we're asking these questions, that it's directly related to their healthcare, that we're asking everyone so they don't feel personally profiled or targeted in any way, that they don't need to disclose if they don't want to, and that we're only going to use it in a confidential way directly related to their care in a respectful manner. Next slide, please. Some staff may need extra coaching and reassurance. They may have doubts or their own implicit bias that interferes with their ability to do this in a sensitive, effective way. And supervisors can explain that health system staff are obviously, respected, that they're not trying to, through this process, change anybody's beliefs, values, religious convictions, political affiliation. This is really about providing universally inclusive care for all patients who walk through our doors. And we can appeal to all staff's sense of idealism in that regard to buy into this work and process. Next slide, please. On our website at LGBTQIA we've developed and have these free demonstration videos with professional filmmaking company, actors, scripts, showing different scenarios, 1 to 2 to 3 minute videos, what you do at the front desk if a patient changed their name, how do you respond if a patient changed their pronouns within a clinical setting, what if a parent comes in with a transgender or gender diverse child, and a range of others. So we encourage you to check these out. You can use these for your own practice or to train your colleagues. Next slide, please. We also on our website have these patient pamphlets on sexual orientation and gender identity. We have these translated into the 10 most commonly spoken languages in the US, and we're going to keep translating, going down that list of languages. These explain why we're asking these questions, why these are important conversations within healthcare, that people can choose not to disclose, that we're asking everybody, that we're going to keep the information confidential and only use it in a respectful way directly relevant to their care. Next slide, please. People may have a range of pronouns, and it's important to not make assumptions, to ask all patients what their pronouns are. We can introduce ourselves with our own pronouns as well. That's a best practice. We have these pronoun pins at Fenway that indicate what our pronouns are that staff wear. Some people's pronouns are ones we're going to be more traditionally familiar with, like he, him, his, or she, her, hers. Many people's pronouns now are they, them, theirs in the singular. So you'd say they're in the waiting room, the doctor is ready to see them. That chart is theirs, for example. This takes practice. That's okay. You may make mistakes initially. Just apologize. Say, I'm so sorry, I didn't mean to be disrespectful, and correct yourself. There are neo-pronouns as well, developed by and for non-binary communities, like Z, here, here's. So Z is in the waiting room, the doctor is ready to see here. That chart is here's, for example. And it's not about knowing every possible set of pronouns in advance. It's more about having a process grounded in cultural humility, where you ask everybody what their name is that they go by, what their pronouns are, ask if you're pronouncing the pronouns correctly, how to spell them, assure them that you're going to document that in the chart, make an effort to use them, let the staff in the practice know, and that the patient should be encouraged to correct anyone if they make a mistake. Next slide, please. LGBTQI+ people have had a range of stigmatizing and adverse experiences, including within healthcare. So we tell staff to not be surprised if they say something and the patient becomes upset. Don't personalize the reaction. Just apologize. Say, I'm so sorry, I didn't mean to be disrespectful, and correct yourself. That's a great way to diffuse a difficult situation and reestablish a constructive dialogue. Next slide, please. You want to think about all the gendered language we've been socialized to use, unpack that, and practice using language that's more gender inclusive and doesn't make assumptions. Like, instead of saying, how may I help you, ma'am or sir, we can just say, hello, how may I help you, and be as warm and welcoming. Instead of saying he or she is here for his or her appointment, we can say the patient's here in the waiting room. Instead of saying, do you have a boyfriend, girlfriend, or a husband, wife, we can just say, are you in a relationship, assuming that's even relevant for the care that they're there for. Next slide, please. We can try to keep up with terminology. You never want to use any disrespectful language or slurs. We don't want to gossip about a patient's appearance or behavior. We don't want to say anything to people that isn't necessary for their care, like you look great, you look like a real woman, real man, which we may think is complimentary, but is actually really off topic and may not be what they want to hear. So if it's not directly relevant to care, we strongly advise to not use it. There's some obviously outdated terms in English, like homosexual, which was a term imposed by the medical community on sexual minority people. Instead, we want to reflect back whatever term the patient themselves uses for their sexual orientation. We don't use the term transvestite anymore, which is a term that was used for people who wore clothing traditionally designed for someone of a different gender. We also don't use the term transgendered, ending in ed, which makes it sound like there was an event that made the person transgender, which is not the case. So instead, we use the term transgender, ending in er, and it's always an adjective, never a noun. So we say she is a transgender woman or a person of transgender experience. We don't say she is a transgender or those transgenders. Always an adjective, never a noun. And we don't use the term sexual preference or lifestyle choice. We use the term sexual orientation to convey that this is an important fundamental part of a person's identity. Next slide, please. Putting this into practice, if you're unsure about a person's name or pronouns, just ask, I'd like to be respectful, what are your name and pronouns? The name they give you doesn't match the name on their insurance or medical records. Just ask in a non-judgmental, helpful way. Could your chart or insurance be under a different name, or what's the name on your insurance? They'll appreciate it. If you make a mistake, just apologize, say I'm sorry, and correct yourself. Don't get flustered, dwell on it, try to convince them that you love watching Pose on TV or have a trans cousin you're very close to. That really centers your own embarrassment and shame rather than their comfort, and we want to focus on their comfort. Next slide, please. And it's important to create a culture of accountability. That means everybody working together in a respectful way. So if someone says something that is insensitive, you can say those kinds of comments are hurtful to other people and don't create a respectful work environment, for example. And with that, I will pass it over to Chris.
Great, thank you, Alex. So now basically what we're going to do is take all the information that Alex shared and figure out how we can actually incorporate this into our daily work. So one of the most important things you can do is really starting your process to begin collecting data and really developing your team, who are the folks who are really going to sort of champion this within your organization. And oftentimes people tend to focus on the clinical side when they're creating their team to implement SOGI data collection. But it's really important to include your administrative and operational folks and administrative staff and non-clinical teams, because they're going to also be interfacing with your patients as well. So for example, your registration team sometimes are the first person that the patient interacts with. So we want to ensure that they're integral to part of the process as well. And within organizations that have been very successful in implementing SOGI data collection and sustaining it, most of these organizations have had what I call an executive champion. You know, we often hear about a clinical champion, but an executive champion is really somebody at a senior management level, maybe some of your leadership team, maybe it's somebody in your board, somebody who really feels like this is an important area for the organization to tackle, and can really make sure that the individuals who are working on this project have the resources that they need and are really championing that cause at a higher level within the organization. And similarly, when you begin this process, think about training everybody in your organization. Again, we tend to focus a lot on training clinical staff, but you want to train your optometrists, your nurses, your security staff, your billing staff, because your billing staff will also interact with your patients, right? They'll call the patients on the phone and have conversations with them about bills, and we want to make sure that they understand the right name and the right pronouns to be using when they're interacting with your patients. So really thinking about this as a whole organization endeavor. There's also issues that are going to come up around privacy and confidentiality, and we'll talk about this a little bit. But generally, I always just sort of think about this in the way that you think about any information that's collected in EHR. You want to keep this private and confidential, just like you keep diagnosis information, name information, date of birth, anything in that way. And I think it's also important to really assure patients that their information always will be kept confidential as well. And we'll also kind of get into how you might customize your EHR a little bit to also support the work that you're doing. Next slide here. So as you begin to think about collecting SOGI data collection, this really can happen in lots of different ways. We've seen the most success in collecting these data at registration, but certainly now with so much of the work that's happening around telehealth, there's really many different ways that you can collect this data. We know that there are a lot of vendors out there that allow data collection at home through like an app or a portal. So certainly that could be one way that you could collect information from their patients on their SOGI status. You could also collect this information when people show up for a visit. So if you have a kiosk, maybe you have paper that people are completing out, whatever mechanism that you work, basically incorporate this into that component of data collection. And something we've also seen organizations who collect this at the time of the visit when they're meeting with their clinician. Again, this works, but we also know that clinicians have a lot of information that they're trying to capture. So sometimes, this doesn't always happen, or sometimes, we've seen situations where clinicians are not directly asking the questions and making assumptions based on the way that the patient answers. So always best to really allow the patients to answer these questions directly. This is a sample of a registration form that we use at Fenway, and I like to use this just to reiterate some of those key concepts that Alex talked about earlier and how you might incorporate this into your organization. So at the very top of our registration form, you'll see here we ask for the patient's name, and oftentimes I describe this as, people talk about this as legal name, but I often talk about this as insurance name, because really this is the information that's going to go out on the patient's insurance claim. And similarly, you also see here where we have another field where we ask the patient for their first name. So we want to always provide that opportunity for the patients to give us the name that they use, right? So name and pronouns as well. You might hear people talk about preferred name, preferred pronouns, but we're really discouraging people to use that term because it sort of gives that idea of that preference, right? We could choose to use it or not use it, but we really want to sort of think about this as the patient's name and the patient's pronouns. In the middle section here too, you'll see that we removed any reference to, you know, mother or father as an emergency contact, for example, and just really try to keep this broad as possible. Parent, guardian, emergency contact's name. We don't want to have, you know, spouse or wife or husband, because not everybody, right, has a mother or father, or people might have two moms or two dads, and so we want to make the forms that we're using as culturally responsive and affirming as we possibly can. And down here below is, you'll see this is where we get into our data collection for SOGI. And you'll see that we incorporated this into our demographic section. So just where we collect race information and ethnicity information, this is where we also ask about our SOGI questions. And we thought that this is very critical, right? Because it normalizes it. We're collecting this just like we collect any other demographic. And the other benefit of this too is that oftentimes when people come in to, you know, register or check in for a visit, it's a natural time where we're asking people to update their information, right? Is your phone number the same, your address, your insurance? So it gives people the opportunity to also update their SOGI information. As Alex alluded to, this isn't always a straight line, and we know that this can change for people over time. And so we want to give people the opportunity to always update that information. We encourage people to do this annually, just like you're updating any other annual information, to ensure people have that opportunity there. This is an example of an organ inventory form that we developed at Fenway, and we recently publicized it too, and we have our publication link in here as well. And the goal of this is really to sort of identify and record a person's anatomy, right? So as Alex was saying earlier, we don't want to make assumptions that just because somebody is male that they have penis, or that somebody's female that they have a cervix or breast. And so this organ inventory is within our EHR system, and it allows the provider basically to document the body parts the patient has and what they don't have. And the real benefit of this is that once they check the box, so for in this example, we immediately add this to the patient's problem list. And so this is really helpful. So this, when we begin to run reports to see who might be due for a cervical pap screening, for example, we can use this diagnosis information to either include or exclude somebody. Because what we don't want to do is send somebody a letter that says, hey, you due for your pap screening, and they don't actually have a cervix. You know, on the converse side, what we don't want to do is miss somebody again who has a cervix, right? And then we're not screening them appropriately. So these kinds of tools and mechanisms that are incorporated into your EHR can be really helpful and really try to close those disparities and close those health and equity gaps. This is an example of a gender inclusive diagram that, you know, we're really encouraging people to use, because oftentimes, you know, we use these diagrams that are very gender specific, right? So it's a male anatomy or female anatomy. But as Alex talked about, there are many people, you know, who are not, who don't have an anatomy in the traditional senses that we, you know, that some people think about them. And so we want to have, you know, tools within our organization for clinicians that really sort of support this notion of you know, working in a you know, in a gender expansive kind of way, and not really making assumptions about the body parts that people have based on their sex. I wanted to just talk a minute about clinical decision support and how this kind of probably works frequently within your work that you do, or within the work that you're doing with the organizations. Because clinical decision support really functions within electronic health record and advises the clinical care team on labs that they should order or procedures that they should be doing. And some examples of some of the current variables that they use are related to sex and age and conditions. So if somebody's diabetes, they should have their A1C done. Medications, if they're on Coumadin, they should have an INR, and so on and so forth. But what most traditional, you know, protocols and clinical decision support tools don't include are things related to sexual orientation, gender identity, sex assigned at birth, and organ inventory. And why is this problematic? So let's take this example of a male who's 52 years old. the system recommends that the patient is due for these labs, right? LDL, HDL, triglycerides, so on and so forth. But what the system doesn't take into account for was that this patient is genderqueer, but also their sex assigned at birth is female. So it's not necessarily recommending a procedure. So for example, does the patient still have a cervix, and should they be having a cervical pap smear? Should they be having a mammogram? And so oftentimes many people are, these procedures are oftentimes missed as a result of that. But let's say, we sort of advance beyond that and we think about ways in which we could begin to include the anatomical inventory into our work and into our decision making. And in this case, for the same patient, we see that this patient now has a cervix, uterus, ovaries, breasts. And so we get a much better idea of what this patient is actually due for. I oftentimes will say, we talk about precision medicine, and to me, this is precision medicine, right? It's really sort of not thinking about these quality measures on this population base, but really thinking about what the individual person in front of you actually needs. So jumping to reporting. So now that we've actually collected these data, we actually want to do something with this information to close these gaps, right? To address these gaps in care. So once we have these data, think about ways in which you can incorporate it into some of your existing work. And again, the organizations that we've seen who are really the most successful in doing this work, don't think about this so much as a standalone project, but think about ways in which they can incorporate into their existing work. So if you're working on an initiative, let's say related to hypertension, look at your data by race, but also look at it by sexual orientation, gender identity, and are you seeing that patients who are lesbian or gay have higher blood pressure or are coming in for fewer visits or whatever that might be. But begin to sort of look at it within those contexts of those populations. You also might think about ways in which you can present data to your senior managers, just to remind them that this is an important population to care for. Sometimes we'll hear people say like, we don't have, any gay people at our organization. We don't have any trans people at our organization. And when they start to run the numbers, they're often shocked to find out how many patients they actually have who are receiving care within their organization. And as you begin to do the analysis, just a reminder, as Alex said earlier, sexual orientation and gender identity are not the same thing. And sometimes people have a tendency to sort of lump SOGI data into the denominator. So just really think about the question that you're asking, and is the question really more related to gender? Should you not really be including sexual orientation in the denominator, or is it question really more related to sexual orientation? And so in that case, you might include that as that variable in your denominator. And when you're thinking about how you would identify patients who are transgender, gender diverse in your patient population, it's really important to use both the sex assigned at birth and the gender identity question. And I'll show you what I mean by that. So this is a two-step question that's widely recommended. What is your gender identity and what is your sex assigned at birth? And so I'm going to walk you through an example of what I mean by why it's important to include both of these. So let's say a patient comes in and identify themselves as a trans male or trans masculine person. And you run your data just looking at the gender identity question. In this case, it would be easy to identify this patient as transgender. But as Alex said, people identify in lots of different ways. So let's say somebody else comes in and they check off that box as male, and you're only looking at the gender identity question. So in this case, you might be making lots of assumptions about who this person is and maybe what they're due for and how to care for them. But when you bring in this patient's sex assigned at birth question and you look at their response, you come to find out this patient is female. So by looking at both of these questions, it really helps, again, to not make assumptions about who somebody is, and ensuring that we're not missing some key areas that we should be caring for this patient. And as you begin this process, it's always important to do data integrity and quality checking. So in this example here, we're looking at patients who were born in the US versus born outside the US. And when we begin to look at these data at aggregate level, we see that the numbers look very similar, right? 40 and 45 for missing this. And we might, if we leave it at that, we might think that there's no problems or people are not experiencing any challenges in terms of answering this question. But when we begin to look at these data proportionally, what we do find out is that there's a very big difference in how people are responding to this question. And so in the case of people who are born outside the US, you can see that the percent is much higher. So this might immediately alert us to challenges that maybe the translation, there's issues with the translation, so people aren't understanding the question, or maybe people are just feeling vulnerable that if I answer this question and identify as transgender, I could risk having something potentially bad happen to me if I'm somebody who's undocumented, for example. But really, you can sort of do this in lots of different ways and stratify this information in lots of different ways to sort of understand maybe who are the new patients coming into your organization, or even thinking about social determinants of health, and which we know that many people in the LGBTQ community are also highly impacted by. And quality measures are, obviously an area that's really important and really important for the work that you're doing as well. And these are just some examples of the ones that, are many of us are looking to meet. So for example, when we think about quality measures, oftentimes we look at a population base. We say 75% of our patients had their mammogram done, or 50% of our patients had an HIV test done in their lifetime. But what we're not doing is actually stratifying these data and actually looking at it by different demographic groups to seeing if people are having different experiences. So this is an example of how you might take your quality measures and stratify it by the SOGI fields to sort of see if you're seeing any differences in the outcome. So for example, are you seeing that your lesbian or gay females are having lower rates of mammograms compared to their straight or heterosexual counterparts? Similarly, are you seeing that your trans masculine males are having lower rates of cervical screening to your cisgender females, for example? So, different ways that you can work through this to identify where those gaps are, and then ultimately put a process or procedures in place to close those gaps. And as Alex mentioned earlier too, we know that the LGBTQIA community experiences higher rates of depression, tobacco screening. So again, all the more important why we want to ensure that we're doing very well in terms of screening these populations. This is an example of a canned report that many people receive from their population health tool. So looking at how compliant people are in terms of meeting these measures at an individual patient level. So this is an example here. We'll work through the very first one where Joseph Smith is listed in the chart as a male. They're 35 years old, and so the system uses their algorithms, and they say, okay, this is a male. They don't need a cervical pap screening, nor do they need a mammogram. But what we come to find out is that when we bring in the gender identity question, we come to find out that, in fact, Joseph is a trans male. So immediately this raises the question, or can raise the question to the clinical care team to say, hey, should we be doing a cervical pap screening on this person? And if this person still has any residual breast tissue, we probably should be doing a mammogram as well. So some of the tools that are actually put in place to actually help us do our job and manage our patients are actually in some ways creating and causing these gaps in care. This is just an example of a transgender dashboard that we put together at Fenway. We have over 4,000 transgender diverse patients that we care for annually. We wanted to make sure that we were really understanding who our patients were, and that we were potentially closing any care gaps and identifying any trends. And so we put together this population dashboard. The first page is really just going over demographics, understanding age groups, race and ethnicity, insurance, poverty level, all sorts of those different demographics where people are getting care at different locations. We also added in a tab looking at screening rates, and as we talked about, the LGBTQ community experiences those higher rates of depression and anxiety, so we want to make sure that we're doing a really good job of screening them. And we also look at other comorbidities. So, for example, what are the HIV infection rates, diabetes, how many people are on PrEP, so on and so forth. And with that, I will stop sharing and turn it over for any questions.
Thank you so much, Alex and Chris. It was great presentations, a lot of information, and you did it within the time frame. So that's good. Good job.
Yeah.
I think we have some questions in the chat. I'm going to ask my colleague Susan to go through the questions.
Thanks, Laura. So yes, thank you, presenters. That was very good information. And we do have a couple of questions. So Lynn Wilson asks, are you finding more accurate or increased frequency of sharing when patients enter their own information on portals or other methods?
Yeah, I can take this one, Alex, if you want to add to it. We actually do find better completeness when patients are entering their own information. There's a number of reasons for this, and this sort of is consistent even with other fields that when people have the opportunity to enter information into a computer, they tend to be more honest with this information. They also have more time to think about it and then respond to the questions. Sometimes I think in busy clinics, again, people just may not have time. They have a lot of information that they're trying to collect, and ensuring that they're getting the right insurance information so that they can get reimbursed, or that they're collecting information so that they can meet quality measures. So there's a lot of a lot of distraction sometimes, and so when we're able to sort of provide patients with that opportunity to complete that information ahead of time, they tend to answer those questions more completely and honestly. Alex, do you want to add anything?
Yeah, that all sounds good to me. I agree with all of it. The thing I'll say is that having patients enter the information themselves through an electronic tablet, for example, at Fenway, or however a given health system operates, doesn't get the organization off the hook from training actual staff to be able to discuss these things with patients, because they may have concerns or questions about why they're being asked for this, or be confused by it, or whatever the case may be. So that is found, as Chris was saying, in studies to be the way to get the most candid answers and most complete responses. We also still always need staff to be trained in sensitive, effective communication and to be able to discuss these SOGI questions with patients.
Thank you both. And just kind of follow up, you mentioned in the presentation about getting that second point of contact with the clinical personnel. What would that look like when the information comes to that next level in verifying or affirming that information?
Chris, do you want me to start with that, and you can follow
Sure.
up? Okay, great. Yeah, I mean, the scenario I was thinking of, which is one we have a demonstration video of on our website dramatizing that, so showing it with actors, is basically the person gets either a clipboard with a form, paper form, or an electronic tablet in the waiting room, for example. They're going through all the demographic questions about race and age and income and whatnot. And in that are sexual orientation and gender identity questions. And then imagine that person walks up to the desk and says, "Excuse me, I don't understand why I'm being asked here for my sexual orientation," right? And then that staff person needs to be able to explain to the person that these are questions we're now asking all patients in order to provide the highest quality of care for everyone, that it's directly relevant to care, that they can choose not to disclose if they don't want to, and can maybe hand them a pamphlet like the ones that I showed, explaining the information more to them in the language that they're best served in, and say, if you have further questions, your provider will welcome your questions. So not getting into a big back and forth at the front desk, providing some information, being able to respond and field that in a good way, but then passing off, more sort of in-depth discussion to the private, confidential, appropriate setting of being with the provider in the visit. So that's generally how we would envision that happening, and why even with self-report, it's important to have staff who are ready to field questions that may come up.
Thank you. You kind of covered this, but in the next question, someone asked, what are some steps that providers can take to ensure LGBTQ plus patients know their practice provides affirming care?
Yeah, it's a great question. The best way to show that to patients is to actually do the work of learning how to provide culturally responsive care and delivering culturally responsive care. And that means training in certain technical skills, right, that are pretty uniquely needed, whether it's hormone therapy, psychiatric evaluation for surgery, certain practices but regarding sexual health or sexually transmitted infections that may be more unique. So having clinicians and care teams trained to do that. It's also creating an inclusive and affirming care environment. From the minute the person walks into the door, are assumptions being made about their pronouns, or are they being asked? Are assumptions being made about the type of romantic relationship that they're in when they talk to the provider? So there's a clinical technical piece, there's a culturally responsive care piece and sensitive effective communication piece. There's information technology, which Chris talked a lot about, to have systems that are being used in a way and harnessed to improve care. And in the marketing materials and brochures that are used for the organization, are you depicting, different types of relationships and a range of gender expressions, for example, in your posters and pamphlets in the waiting room? Are you engaging community in the life of the organization? That's really important. So do you have community advisory boards and that are representative of the full diversity of the communities you seek to serve? Do you have patient satisfaction surveys that you're doing that get at the extent to which LGBTQI+ patients are satisfied with their care, so you can engage in continuous quality improvement based on that? Are you honoring important events like Pride in June, Intersex Awareness Day in October, Transgender Day of Remembrance in November, and so on? And finally, do you have staff that reflect the full diversity of the communities that you seek to serve? What are your recruiting, hiring practices? Are you retaining LGBTQI+ staff so that you reflect all communities that you serve? Are you mentoring them? Do you have benefits that are covering gender affirming medical care? Are you promoting LGBTQI+ people into positions of leadership within the organization? All of these things matter and are very much felt by our patient populations. Chris, I don't know if there's anything you want to add to that.
I think you covered it.
Great. And one more question, and this is a good one, because you mentioned the forms and how you collect information, but are you finding that EHR vendors are modifying their systems to accommodate the care for these patients?
Yeah, so this is, Alex, I'll take this one, and you feel free to add on. We're definitely seeing a lot of forward movement in this direction. A number of years ago, the Office of National Coordinator of HIT, as part of their meaningful use initiative, which was many years ago, required that all certified EHR vendors had a place to record sexual orientation, gender identity. And so really any large commonly used EHR at this point has those fields within the system. We've continued to see some forward movement by some vendors, some of the larger vendors. Epic is doing a lot of work and continuing to advance their internal clinical decision support tools that are honing that and refining that to actually do a better job at advising the clinical care teams on what a patient is due for, some of that work that I talked about in the slides earlier. Athena Health recently held a multi-day sprint to actually do some work and improve some of their data capture and do some of the similar work around clinical decision support as well. So so there's definitely some vendors who are actively working on this and continuing to really propel forward. There's also a lot of movement that's happening at the federal level. So, for example, the United States core data set recently came out with the required data fields, and SOGI was included in that, which is a very impactful and will sort of nudge a lot of EHR vendors to begin to do that work, because they'll have to accommodate to meet those the US CDI standards. There's also a group that's been actively working within the HL7 environment called Gender Harmony. That's also building out the fields that can be used to, for interoperability, to be used to be exchanged between systems. So things like name and pronouns and gender identity. So up to date, this is not really transferred between systems. And so the Gender Harmony group is basically putting that structure in place that will allow that information to be shared, across, clinical organizations. So there's definitely a lot of momentum happening, but more work to be done. But definitely some good work happening.
I think there was one more question that just popped up in the chat.
Yes, it did, and it's kind of a practice of this organization. So we have someone who is in an acute care hospital setting. Some of their trans patients have stated that they resent asking sex assigned at birth during registration process. They explained to the participants to report normal values that are based on sex assigned at birth, so it's important to collect the information from a safety and quality perspective. And they also do not ask if anyone is on hormone therapy during registration, which may impact normal lab values reference points. Any thoughts from either of you on that?
I'm happy to start. Chris, you can continue.
Sure.
I also have a presentation I'm giving right at 12 for another group, but there is a lot of discussion in the community about the sex assigned at birth question, because a lot of people don't want to be reminded of their sex assigned at birth once they've been affirmed in their gender identity. So we definitely hear that a fair bit. Sex assigned at birth, is helpful in a variety of ways. I don't know that I don't agree with the reason stated here that it's to report normal lab values based on sex assigned at birth. Lab values aren't necessarily better based on sex assigned at birth. And I think referring to normal lab values is probably going to make a lot of trans people bristle anyway. So I don't think that the rationale given here is going to be particularly reassuring or comforting to trans people, but there is a place for sex assigned at birth, particularly with regard to population health management as well, and some of the kind of crosstabs that Chris showed to indicate how we can identify inequities across the health system or population. But Chris, I'll leave it to you to answer this in more detail as well.
Yeah, no, I think Alex really covered it. I mean, I think, the primary reason about this is really to ensure that we're really providing the best care. So, I gave a number of examples around, cervical pap screening or mammograms, but it also prostate, right, screening. So there's lots of ways in which we would really need this information to, make sure that, we're not missing any key procedures that the patient should be due for. And I might be interested to ask, or maybe get a little bit more information from the patient, if it's just that they're feeling unsafe, or they're feeling that the information is confidential, like, because, maybe there's something, that could be going on there, where there's just, concerns around that aspect. So it might be good just to gather a little bit more information about that too from them.
So Chris and Alex, thank you so very much. We're actually a little beyond the top of the hour, but thank you so very much for joining us today. It was two great presentations and for answering those questions. On the screen, I have contact information for the IPRO Health Equity teams, and here's all of our social media information. Thank you all so very much for joining us today, and enjoy the rest of your day. Take care.
Great. Thank you so much.
Bye-bye.
Bye-bye.